The healthcare bill is now law. What does that mean to you, your family, your small business? North Dakota Senator Kent Conrad is here to explain next. Hi, I'm Matt O'Lean. Welcome to the Healthcare Law, What It Means, a partnership between Prairie Public and AARP. Well, the political dust has settled. The bill is now law. So the next half hour, we're going to try to answer your questions that you may have out there. What does this law mean to me, my family, whatever may affect you? North Dakota Senator Kent Conrad is with us for the next half hour to explain the nuances and the subtleties. Thank you for being here, Senator.
Good to be with you, Matt.
Well, this is going to go quickly because there's a lot to get to, so let's get right to the nuts and bolts. The big question I hear people ask, how's it going to be paid for? What's the cost? Will my premiums go up?
Well, let's start with the cost of the bill. Over 10 years, it's over $1 trillion, but that is more than offset with the pay-fors. The biggest pay-for is reductions in the increases that certain Medicare providers were scheduled to receive. So, for example, the hospitals are not going to get as big an increase as they were previously forecasted to receive. And these were largely negotiated reductions. Reductions in increases, I think, is a more accurate way to put it, because they're still going to get increases, just not as big as they were before. Why would they agree to take less of an increase? Well, in the case of hospitals and home health agencies, because they're going to have more customers. They're going to have 30 million more people who have insurance. That's going to reduce their uncompensated care. And so as they looked at the total picture, they were ready to take less of an increase from Medicare in exchange for getting more people with coverage.
Okay, how about a family out there, a family of four? I have my insurance through Prairie Public. I have 2 kids. What does it mean for, you know, the average like two-child family out there with your insurance through work?
Really not much change for people like that. You know, this whole thing builds on the current system of employer-based coverage. And despite what some people have said, that this is a government takeover, that's just not the case at all. This is building on the current private insurance, employer-based coverage that we have, that the vast majority of Americans have. You will see some changes that are, I think, improvements. For example, no lifetime limits on the coverage that's available to you. They can't use pre-existing conditions to block you from getting coverage. That's going to be very important to people. I've heard so many cases. People who were ruled out of coverage that they thought they had because of a pre-existing condition. That is going to be stopped. The process of rescission, whereby people who've paid for their insurance for many years get sick, and all of a sudden the insurance company says, well, we're taking your insurance away. That bad practice is being eliminated. So for most people, those are the changes that they'll see.
What about premiums, though? Because I hear people out there saying, oh, my premiums are going to go up. I'm scared about my premiums going up.
Yeah.
Do we know that, or is that still kind of an unknown, Senator?
Well, this is what the Congressional Budget Office, which is nonpartisan, told us as we were writing the legislation. First of all, premiums are going up with or without this bill. We all know premiums are going up. For the vast majority of people, according to the Congressional Budget Office, they won't go up more because of this bill, or they will go down slightly. That's for the vast majority of people. For a relatively small group of people, 10 or 15% of the population, their premiums will go up over and above what would have happened absent this legislation. But CBO concluded it will go up for them because they will have better care available to them, and they will choose to pay more to get that better quality coverage.
Okay. 2014, that's kind of this target year we keep hearing about, that everyone will be insured by then, kind of like car insurance. How is that going to happen? That's another question I hear when I'm out in the general
Yeah.
public is, how in the world can we cover everybody in 2014? What's it going to cost? I assume there's subsidies, Senator, that
Yeah.
are involved?
Well,
Because some
first of
people,
all-
we're talking about people that can't afford it right now,
Yeah.
I assume.
Not everybody is covered.
Right.
There is a significant increase in coverage. About 30 million people who don't have coverage now will be able to get it, and they'll get it in a variety of ways. They will get it by assistance for those who can't afford it. They will get it because employers are being given tax credits to help them afford coverage. For example, in North Dakota, the estimate is some 17,000 of our small businesses, because of the tax credits that will be given to them, will be eligible for tax help from the government to extend coverage to their employees.
These are, I assume, businesses like you and I know, the mom and pop businesses. Maybe they have under 20 employees and they don't offer insurance right now. Is that, I know there's a lot of fear amongst that group. Is that what you're talking
Yes.
about?
This is for businesses that have fewer than 25 employees with an average wage of less than $50,000 per employee. They're eligible for tax credits, tax assistance to extend health care coverage to their employees.
I do want to mention, if you want more information about any of this that we're talking about, there it is, www.conrad.senate.gov. That's the website to go to. And at the end of this program, you'll also see the AARP and Prairie Public websites, which will have some linking information as well. Okay, small business subsidies, you mentioned that, and I have written down about 90% will be eligible for that. Is that a ballpark? Or?
Almost 90% of North Dakota businesses fall in that category. Fewer than 25 employees with an average wage of less than $50,000 a year.
Okay. Let's get to Medicare. Older Americans that are on Medicare, again, I'm sure you've been at some town hall forums. People get very nervous about this. What is that going to mean for people 65 and over?
Very important to say, there are no cuts for guaranteed Medicare benefits. Some people say, well, but there are savings out of Medicare. How can it be that there aren't cuts to beneficiaries? Well, there are savings out of Medicare, some $600 billion over 10 years. But those cuts are, those savings are from providers. They really aren't cuts in the sense they would get less than the year before. They just get less of an increase. And again, the reason they have agreed to those savings, by and large, not all of them were agreed to, but the great majority were agreed to, is because they see they're going to get more customers. They're going to have 30 million more people with insurance. That means less uncompensated care. That means they can afford to give up some of the increases that were projected.
I remember when the debate was going on, and not that we're going to dwell on the debate, but there was some chit-chat about just closing that loophole and maybe offering Medicare when people turn 60 or 62. Why was that considered unworkable? I know that was one thing that was being thrown around during the debates.
Yeah, it really cost.
Okay.
And when we talk about the Medicare eligible population, we should be swift to point out that one of the big additional benefits that they will be getting is closing the donut hole on their prescription drugs. That affects something over 9,000 people in North Dakota who hit the donut hole. That's the point at which they stop getting assistance with their prescription drugs. That donut hole will be eliminated over 10 years, starting with next year a 50% reduction in prescription drugs. So that's a big benefit for people who are Medicare eligible. And of course, an additional benefit that also takes place very soon is the reduction, the elimination of copays for preventive care. So screenings for mammograms, for cancer, screenings for diabetes, vaccinations. There will no longer be a copay required of people who are Medicare eligible. And the idea is to move towards a prevention approach, a wellness approach, instead of just focusing on illness.
How about the future with Medicare? I mean, everybody's living longer now, and I know they talk about the solvency issue, and maybe this is a separate issue, but it does tie in. Yeah, how do we make sure that's solvent in the future?
Well, it's very important. The trustees' report just came out, and it said that this health care bill extends the solvency of Medicare by 12 years. So that's a significant improvement from where we were. It's not enough. Much more is going to have to be done, but this is certainly a step in the right direction at improving the solvency of Medicare.
Can you explain in layman's terms what the donut hole is? Because we hear that all the time, and I know you talked about it, but what exactly does that mean?
Well, the donut hole works this way. You get help on your prescription drugs up to a certain dollar amount of cost per year. Then you hit what's called the donut hole, at which government support fades away, the assistance is not there, and so it's an out-of-pocket expense for Medicare beneficiaries. Then at a higher cost, the assistance comes back. That's why they call it the donut hole. So there's a certain dollar amount of expenditure for which you are responsible out of pocket with no assistance.
Okay. And prescription.
And that donut hole is going to be eliminated over a 10-year period.
Okay. How do you see prescription drug prices going with this new health care law? Because that's always been an issue here. People going to Canada. I know Senator Dorgan's been involved with this issue a lot.
Really, this legislation does not fundamentally affect prescription drug prices. It does affect the out-of-pocket expenditures by seniors by eliminating that donut hole, so it helps them in that way. But this legislation fundamentally does not address prescription drug prices.
Okay, that's going to have to be addressed separately.
That is going to have to be addressed separately.
Okay. That's still a big issue, obviously, right?
A very big issue, and Senator Dorgan had some of the most important legislation, something I was proud to support, to allow reimportation from Canada of the lower prices that they enjoy for exactly the same prescription drugs. And we were able to pass that. It wasn't included in the final package because of negotiations between the bodies, between the House and the Senate.
I do want to mention again the website if you want more information, www.conrad.senate.gov. There it is. People want more information after we're done here, want to look up that. And also you have the AARP and Prairie Public websites, which will be available at the end of the program. Let's get to the Frontier Amendment. There was a lot of talk in the debate about the rural states. Ben Nelson from Nebraska, that was a political football, of course. What is the Frontier Amendment? What does that mean to North Dakota?
Senator Dorgan and I offered an amendment to reduce the unfairness to the most rural states in the country, the so-called frontier states. These are states that have had the lowest levels of reimbursement in the country for Medicare, going to our hospitals and going to our doctors. And so the amendment that was offered, the so-called Frontier Amendment, will bring us up to roughly the average of Medicare reimbursement around the country. And there are 4 or 5 states that are eligible, that are going to be helped by this, the most rural states in the country, who have really been treated unfairly for many years. So I'm very proud of that. It's going to be very important to our state. Already the hospitals have said without it, they would have been faced with reducing services, with laying off people, and those threats have receded as a result of this legislation. Very, very important to North Dakota and the other rural states affected.
How many states did that affect approximately?
I think there are 5 states that are affected, that are eligible. South Dakota, certainly one. Wyoming.
Right. So rural health care, obviously a huge issue in this state, getting access to people and things like that.
Absolutely. And North Dakota has been in this anomalous situation of having one of the highest quality care states in the top 5% in quality outcomes, but at or near the bottom in reimbursement. And it's because of formulas that are badly outdated, based on historic cost. And of course, our historic costs are low. But now when we go to recruit a doctor, they don't say, gee, we see your reimbursement's low under Medicare, so we'd be willing to take less of a salary. Or our hospitals, when they go to buy technology, they don't get a rural discount. In fact, we probably pay more for technology because we're not buying in as much volume as the larger population states. And, you know, this is frankly a circumstance in which the large population states have been able to write formulas that were advantageous to them. Those of us who come from more rural states, you know, we only have 1 member in the House of Representatives. California's got 50. So when they go to write the formulas, you can imagine they write them in a way that benefits them.
When you're out meeting with the public, Senator, what are the questions you get asked most often with
It's
this
interesting,
bill
Matt.
and law?
I just had this conversation with my wife, and she said, Kent, I've heard you say that the Congressional Budget Office projects that this legislation will reduce the budget deficit. She said, I can't believe that. How can it be that we cover more people and somehow the deficit is reduced? And I said to her, it's very simple, really. It's because the pay-fors here are more than the additional cost. And the pay-fors are, as I indicated, savings from Medicare providers. In addition, there's an additional levy on those who make over $250,000 a year on their unearned income. They're going to face an additional levy of 0.9%, a very modest increase. There's also levies on those who benefit by having more customers. So, for example, prescription drug companies are going to pay an additional fee to help finance this overall effort. The combined impact, according to the Congressional Budget Office, is to reduce the deficit over the first 10 years by $143 billion, over the second 10 years by more than $1 trillion. Reduces the budget deficit over the second 10 years, according to the Congressional Budget Office, that is nonpartisan, by more than $1 trillion. You know, one of the things, Matt, that I think has gotten lost in the discussion are the fundamental reforms that are in this legislation. Not only insurance reforms to do away with the exclusion on pre-existing condition and do away with rescissions where people lose their coverage even though they've paid the insurance for many years but lose it when they get sick. Those things are reformed, but even more fundamental is reforming the way we pay for health care. All of the experts, or virtually all of them, came and told us, look, right now you pay for procedures. As a result, you get a lot of procedures, whether they make people healthier or not. And Dartmouth did a big nationwide study and concluded about 30% of the cost of health care does nothing to make us healthier. And so in this legislation is a provision to, instead of paying for procedures, to begin to pay for quality outcomes. This is a national pilot project, and as it proves effective, it will be spread across the nation so that we begin to pay for quality outcomes rather than paying for procedures. In many ways, it's the most important piece of this bill, and yet it's received very little attention.
Yeah, I was going to say that is something that you don't hear people talk about a lot. How is that going to be implemented then?
It is implemented by first starting a pilot project to encompass the best
Does
ideas.
the hospital do that, or who does that?
Well, the CMS does it.
Okay,
That's
okay.
in charge of our healthcare
Okay.
system in this country. They will put out a number of experiments to change this payment model. And those that work are immediately authorized to be spread across the nation to be effective all across the country. Frankly, I think it's one of the most exciting parts of the bill.
Okay. There was a lot of talk, Senator, about the Cadillac insurance.
Yes.
Yeah, with the labor unions, I know we're very concerned about that. What ended up happening with that in the final law?
What ended up happening, Matt, is for policies that have a value of more than $27,500 a year, the companies that offer those plans will face a fee or a tax. So, you know, the vast majority of plans in North Dakota are way below a value of $27,500. There'd be just a handful of plans like that in North Dakota that would have a value that high for a couple, $27,500 a year. But over that amount, they will begin to face a levy. Again, most of the healthcare experts in the country said these Cadillac plans are contributing to overutilization and the explosion of healthcare costs. And one of the most important things that we could do to rein in that exploding cost is to deal with a levy on Cadillac plans.
Okay. You mentioned the pre-existing conditions. Now, did that go into effect now, or is that in 2014, where someone can't be dropped or can't be denied for pre-existing conditions? Because I hear a lot of that too.
Yeah.
Does this part go in now? Does this part go in 4 years? That kind of thing.
6 months after enactment, which will
Okay.
be toward the end of September,
Okay.
the pre-existing condition exclusion will apply to children on all new health care plans and all existing group plans. It will not apply to individual plans. But so for children, starting I think September 23rd is the
Okay.
exact date, they will not be able to exclude children based on pre-existing condition in existing contracts or existing group plans or any new health care coverage.
So let's say that 50 to 65 group, that's a group that sometimes people get denied because someone's developed. How does that affect them then? When does
Very,
that?
very important.
Okay.
For those by 2014, the pre-existing condition exclusions will no longer be able to be used on anybody.
Okay.
And
That's going to take about 4 years to get everybody
yeah,
into
because
that.
most of
Okay.
these, the whole structure of this, most of this plan does not take effect until 2014 because this is a giant ship, medical care in the United States. So to turn it just a little bit now will have a big effect over time. But you've got to give time for the transition. You've got to
Phased
give
in,
time
yeah.
for it to be phased in. People said to us, hey, don't just go out there and change things immediately. Have a transition period so people can adjust. And that's what's been done here.
How about the provision, Senator? Let's say I'm a college student and I want to stay on mom and dad's health care coverage. They can do that now up to 26?
Yes, you're able to
Did
stay.
that one go in right away, or is that phased in too?
That is something that I think is also 6 months after
Okay.
enactment. I might be wrong about that. I think it's 6 months after enactment, which would again be in
Your
September.
website would have that though.
It would.
Conrad.senate.gov.
And
Okay.
what that provides is that children up to the age of 26, are able to stay on their parents' policies. I just had 2 sets of parents talk to me about this in the last week, people who came to see me in Washington and say, boy, that's important to me. My child keep going to school, or he's got a job
Or
but
can't
doesn't
find
have
a
health
job,
care,
right.
or can't find a job, and this is going to allow them to stay on our policies. Very important to people.
Okay. And another question here. We've got about 4 minutes to go. The lifetime catastrophic coverage cap. How is that affected by this? Because there's some people get to that cap and then all of a sudden the insurance won't pay out anymore if they have a
I tell you,
terminal illness or something like that.
Some of the
cancer.
most moving
Those are the
stories
stories that really,
that came to me were parents who had children with extremely rare and serious illnesses that then bumped up against their lifetime caps, their lifetime coverage. And boy, your heart goes out to them. Can you imagine? I mean, first of all, having a child that was ill, I can't imagine anything worse than having a child that had a chronic, serious illness. But to have an illness so severe that would cost more than $1 million to provide care, and you find out that your insurance policy has a lifetime cap of $1 million. I've had couples come to me in tears, explaining that they had no idea that they were getting good help, had very traumatic illnesses with their children, and then they find out they're up against a lifetime cap and all assistance is going to stop. This legislation will take away lifetime caps. And so people won't have to deal with that in the future. And that's a very important thing.
and that'll be phased in as well, I assume. That's not something that happens now or September. That's probably going to be phased in over 4 years. or what's
Again, most of these provisions don't take full effect until 2014.
But that was a key one, though, the lifetime cap coverage. That's gonna-
Lifetime caps, and if I'm not mistaken, the lifetime caps come off now.
Okay.
That is something that takes almost immediate effect. Again, I think it's after 6 months after enactment which would be towards the end of September of this year.
And go to, again,
And that's true of the rescissions.
Right.
Rescissions, this bad practice where they were taking coverage away from people who had paid for years, that takes effect 6 months after enactment. The end of lifetime caps, that takes effect 6 months after enactment. And 6 months after enactment is, I think, September 23rd of this year.
Okay. And again, conrad.senate.gov. We got about 30 seconds left. Maybe just some final thoughts, your thoughts about what people need to know. We've covered, I think, pretty much everything, but just some final thoughts.
Let me go back to the basics.
Okay.
Those who have said this is a government takeover, that's just not true. The government is not running this healthcare system. This is based on our current system of coverage based on your place of employment, by and large, and it's private insurance. It's not government insurance. Number two, that does not help for people who are here illegally. They are specifically prevented from getting help under this law. Okay. Number three, I think it's very important for people to understand this is fully paid for, and according to the Congressional Budget Office, will reduce the deficit, reduce the debt. Okay. So those are important principles.
I do need to stop you. We are out of time. It goes very fast. Thank you, Senator, so much. Again, conrad.senate.gov and the AARP and Prairie Public websites you'll see in just a minute. Thanks for being here.